having me look elsewhere. Okay, I'd like for us to get started. And everyone, my name is Joanne Kim, and my primary research interests are in suicide prevention and suicide risk assessment. So today I'll be presenting on a study of mine and of my mentor, Dr. Edward Selby, on factors that influence the disclosure of gun access and suicidal thoughts and behaviors to medical and mental health care providers specifically. This will be using data that I will soon begin collecting online via Prolific. Before we dive in, I want to share the following disclosures. We've been very fortunate to receive support from the New Jersey GVRC, and we have no conflicts of interest to disclose. I'll first provide a high-level background on how inaccurate disclosure of suicidal thoughts and behaviors, or STBs for short, complicates suicide risk assessment, what research so far has learned about the barriers to and facilitators of STB and gun access disclosure, as well as what some of the next steps are in this literature, which my study hopes to tackle.
Excuse me, Joan. We
Yes?
can't see your slides. Could you
Oh,
share your
no.
slides, please? Thank you.
Yes, I will. I think I deselected it somehow. Here we go. Let me know if you see that.
Perfect. Thank you.
Beautiful. Okay, very sorry about that, and thank you for letting me know. Okay, you haven't missed much. You just missed the title slide. Okay, all right. And so from then on, I'll walk you through what some of the next steps are in the literature, which my study hopes to tackle. I'll then outline what the study aims are and the methodology. So if you have questions or need clarification, feel free to jump in at any point. As you may have heard earlier today, firearms and suicide are leading contributors to death in the US. Research has shown that firearm access is a risk factor for suicide beyond the effects of numerous covariates, including even depression, suicidal ideation, and prior suicidal behavior. And further, data indicate that suicide is more than 5 times as likely in homes with a gun. On the left, you'll see that gun suicide rates have increased over the past 20 years. The link between gun access and suicide becomes even more obvious when you look to the right, when you see that suicides account for more than half of US gun deaths. And of all deaths by suicide in the US, more than half are gun related or represent guns as the means of suicide. An unusual finding I want to point out is that for females, which you'll see on the right, gun related suicide has recently overtaken poisoning and become the leading means for suicide, which is very uncommon. You can see this very top line for women indicates poisoning as the means, and this indicates firearms. And these are some of the recent changes that we've been seeing. Unsafe storage, which can mean, for example, having an unlocked loaded gun. So unsafe storage of firearms is associated with greater suicide risk. Unfortunately, unsafe firearm storage seems to be very common, which highlights the importance of identifying suicidal individuals with access to guns in order to provide lethal means counseling to prevent death by suicide. And so medical and mental health care providers might be really well positioned to ask patients about firearms and engage in lethal means counseling. To provide some context, not only have guns become a greater factor in suicide, but suicide itself overall is a leading cause of death in the US, and rates have increased for the large part in the past 20 years as well. And that increase has further driven research efforts to better understand how we can more accurately identify people at high risk for suicide and provide them with needed mental health services. And that urgency among public health officials and medical or mental health care providers to improve suicide risk assessment and interventions is amplified given estimates that for every suicide death, there are far more hospitalizations, suicide attempts, and individuals experiencing suicidal ideation. Assessing suicide risk relies heavily on obtaining accurate information about one's history of suicidal thoughts and behaviors to inform categorization of current risk and intervention selection. So, for example, evidence suggests that suicide attempts confer the greatest risk for death by suicide in the 6 months to 2 years immediately after a suicide attempt. Therefore, an individual with a recent suicide attempt might be considered to be at higher current risk for suicide and may need a higher intensity intervention than an individual who experiences suicidal ideation with no method, plan, or suicidal behaviors. This chart on the left depicts an example of how clinicians may categorize current suicide risk and select a certain intensity of intervention based on what they know of the individual's history of STB and other risk factors. So this figure is from Chu and colleagues in 2015. These are recommendations for suicide risk assessment and intervention. So as you can see, it asks, is the person a multiple attempter? And based on your yes or no answers to whether they have resolved plans and preparations or elevated suicidal ideation and desire, you would take a divergent level of care according to the right-hand box, and it tells you exactly where to go. Now, throughout my clinical training as a clinical psychology doctoral student, I, as well as my colleagues, have, with varying amounts of preamble, validation, context beforehand, asked the client the question, do you have thoughts of suicide or of killing yourself? And also, have you ever made an attempt to harm yourself in which you had at least some intent to die? And while many clients who answered yes, or they did answer yes, and we collaboratively created crisis plans and tracked suicide ideation severity and behaviors over the course of treatment, I've also received responses like these, and maybe you have as well, especially this one. While this isn't always the case, these are responses that I have received from individuals who later disclosed that they have been experiencing suicidal ideation or had a previous attempt when I had first asked, but were reluctant at the time to share that. Suicide prevention research has focused on the opportunity that we as medical and mental health care providers have to identify at-risk individuals in routine medical appointments in a setting where they can more easily get care. And so since the process of suicide risk assessment will be heavily dependent on accuracy of disclosure from the client, it's kind of disheartening to know that there's evidence to suggest that clients conceal STB from their medical and mental health care providers. So, for example, qualitative studies have actually shown that clients with current suicidal thoughts choose to conceal this information from even their therapists. And research in this area suggests that clients encounter multiple barriers that make it difficult to accurately disclose STB to medical and mental health care providers. These are some of the most consistently reported barriers to STB disclosure: worry regarding adverse consequences, previous negative disclosure experiences, whether with a provider or with somebody else in their lives, like family or friends. And stigma is not only a reported barrier, but it has also been previously identified as a risk factor for suicide itself. That can include self-stigma, which is internalized stigma about suicide, or public stigma, so your perception of what the community thinks about people who die by suicide. Good news is that despite those barriers, research suggests that there are also factors that may help make it easier to report STB accurately, and those are called facilitators. So studies across folks with, I'll just pull these up right now. Studies across folks with lifetime suicidal ideation to a suicide attempt show that a desire to receive support and help coping with distress may contribute to wanting to open up and accurately disclose STD. Having trust in healthcare providers and the opportunity to access mental health treatment is another possible facilitator of disclosure. Factors that influence firearm access disclosure, on the other hand, have been even less studied. So some studies provide conflicting evidence showing that white respondents, older individuals, and those with more pro-gun attitudes are more comfortable disclosing gun ownership. And other studies found no racial group difference, and that older individuals and those with pro-gun attitudes are less likely to respond. That highlights the need for us to better understand the barriers and facilitators to disclosing firearm access, and to explore perhaps whether firearm access disclosure may be more feasible than STB disclosure to facilitate safety planning, even without accurate STB disclosure. Okay. There's still much more to learn, about what gets in the way and may help increase accurate STB disclosure. There's been less focus on barriers to and facilitators of disclosure to a medical provider or mental health professional specifically. There has been quite a number of studies done on factors that influence disclosure to loved ones, such as family and friends. And so this situation is most relevant. The situation with mental health care providers and medical providers is most relevant for connecting individuals at elevated suicide risk with mental health treatment. There's also a need to better understand whether disclosure is more or less accurate among those we would consider to be at higher risk for suicide. For example, if those at higher risks report STD less accurately, we might be especially concerned. There are also a number of studies that operationalize STB disclosure in a dichotomous yes, I disclosed, no, I did not disclose way. These studies have taught us very much, and people may vary in the degree to which they report accurately. So the current study will examine the continuous degree of accuracy of STB disclosure and of current intention to disclose future STB. And lastly, studies have helped us learn a lot about disclosure of suicidal thoughts, and more attention should be paid to factors that affect disclosure of behaviors. And so the current study is going to examine disclosure of suicide attempts. This brings me to our study aims. We'll assess factors influencing accuracy in disclosure of firearm access and STB and participants' reasons for disclosing or concealing any aspect of their firearm access or STB. And I expect that fear of adverse consequences, suicide-related stigma will emerge as barriers, and also perhaps the idea that they don't want the provider to stop them. While trust in healthcare providers and desire to access treatment might be facilitators. And given the early state of research in gun access disclosure, no a priori hypotheses are established for that realm. The second aim is to examine differences between individuals as a function of accuracy of past STB gun access disclosure and of current intention to disclose future STB or gun access. So overall, I do expect there to be significant differences. And I hope to learn whether those considered to be at greater suicide risk might be less likely to accurately disclose STB. So I would guess that those who do not report STB accurately demonstrate more suicide attempt history, less treatment history, greater suicide or treatment-related stigma, greater endorsement of interpersonal theory of suicide-related variables, greater identity-based hopelessness, and lower intention to disclose firearm access in the future. And I'll run similar analyses to explore differences in these constructs according to accuracy of firearm access disclosure. And that's broken out into these two sub-hypotheses. So as you can see below, I'd expect greater suicide attempt history, higher stigma, and these variables, and so on. I also expect that, again here, that those who report lower past accuracy will report lower current intention to disclose to a medical provider or healthcare professional in the future. I also see this study as an early step to a future study in which I develop a brief and scalable intervention to be provided by medical and mental health care providers to patients that may increase STB disclosure. So I hope to use that data to make recommendations for future steps for assessment and intervention of gun access and STB by medical and mental health care providers. Here's a little bit of what that solicitation of advice might look like from patients. But I really want to dive more into the procedure of the study, where for my procedure, I am aiming to recruit 167 adults, actually hoping to have a minimum of 100 adults that have complete data and that are hopefully not bots. So there are technically two specific ways they can be eligible. Either they report having experienced lifetime SI or suicidal ideation. They've been asked by a medical or mental health care provider if they have SI, and they did have SI at the time they were asked. Or they report having a past attempt. They have been asked about this by a provider, and they did have an attempt at the time they were asked. I'll recruit them via this online platform called Prolific. And exclusion criteria include having a history of a psychotic disorder. Now, Prolific is an online data collection platform like mTurk, if any of you have used that before, but there are some I would say major improvements in terms of the type of participant sample that you can collect. You can get a demographically representative sample, and they have better, from what I understand, vetting to make sure that you don't really get bots in your sample. So the left is for participants and right is for researchers to set up their studies. The study will lead them to, or rather the prolific page will lead them to the pre-screen on Qualtrics. And if they're interested, they click on, yes, I'm interested, and they go forward. Here's what that looks like on mobile. And I did a bit of a screen share of me going through the pre-screen and where it takes you. So that is the initial interest. That was the initial interest page. This is now the pre-screen where you enter age and answer the very questions that I outlined before. And now here is where I try to figure out whether you have been asked about suicidal thoughts or attempts by a medical or mental health care provider specifically. And so I have them select all that apply to them, and they're only eligible if they select a medical or mental health care provider and not if they only select family or friends. And I do debrief the participants afterward. I'll move on from there. This is an example actually of what the full pre-screen survey would look like. So the questions are on the left, response options are on the right, and the eligible answers are in bold, and the question source is on the right. The first 3 questions assess whether they had a suicidal ideation at the time they were asked, and the bottom 3 assess whether they had an intent. And everybody who sees the screener will be presented with National Suicide Prevention Lifeline information. Okay. High level study participation, has informed consent, pre-screen, and then the actual longer study survey. And there's the compensation rate as well. We are going to be using the Experiences with Suicidal Ideation Disclosure Scale, which is a relatively new measure I'm really excited about. And it specifically measures what we are looking for. At the time, were you having thoughts of suicide? And about how many years ago did this occur? So we can look at recency as a factor. This is what the actual Qualtrics survey looks like. To what degree did you accurately express your current thoughts of suicide, right? So this is the continuous variable. They can select what factors or concerns were barriers and what factors were facilitators. Overall, to what extent was their reply helpful versus hurtful? And after this, how likely would you be to be honest if they asked you again, if you're having thoughts of suicide? That's how we measure those particular variables. And I previously mentioned I wanted to better understand the degree to which people are accurate in disclosing STD. So I'm adding this follow-up question. If you had a past suicide attempt, the example here will be in basically the same question, but how likely is it that you would tell this to the following people or use the following services to tell someone about those behaviors in the future? And there we have mental health professional, for example. I plan to control for the following socio-demographic variables, which I won't go into in too much depth. And I am hoping to, it's no surprise at this point, but I'm expecting that participants are going to endorse multiple STB disclosure barriers. So maybe worry about adverse consequences, concerns about confidentiality, as well as facilitators, so access to mental health treatment seeking support. And then I'll have some descriptive statistics showing what those factors are in order of what factor was most commonly endorsed. I will also examine differences between individuals as a function of accuracy of disclosure, past disclosure, and of current intention to disclose in the future. This is the general analytic plan that I can talk with you through if you have any questions later. Yes, if you do want to send them over to me, I'm happy to answer them. And just to get perspectives from participants on what we should do better. Then I can walk you through the analytic plan if you'd ever like, but my overall goal is to identify factors and provide recommendations that may enhance accurate identification of individuals at risk for suicide, to provide them with needed support, including lethal means safety counseling, and to better understand whether individuals we consider to be at higher risk for suicide are more or less likely to disclose gun or STB disclosure. And I hope this research will build on existing suicide prevention efforts in medical settings, such as the zero suicide model, the assess, intervene, and monitor for suicide prevention model, and these as well. And there's room for progress in preventing suicide, whether with guns or anything else as means. And I hope this will be one step that helps in this effort. I'd love to hear your thoughts, questions, concerns, suggestions about the project. So please send them along if you'd like. I will put my email here as well. And that is all. Thank you so much for being here. Do feel free to reach out with any questions whatsoever. Thank you, everyone.